Good morning, everyone. Welcome aboard. I'm Lakshmi Sadasivam. I'm the Patient Safety Officer here at All of You. I'm glad to be here and to talk to you about patient safety in general, what we do at All of You and DHS, and how you as new house staff play an important role in keeping our patients safe. So let's start with origin of patient safety programs. So Dr. Lucian Leape is considered the father of patient safety movement in United States. So he published this paper in JAMA, Error in Medicine, in 1994, and it was the first paper on the subject. And he subsequently published a book via Institute of Medicine called To Err is Human. And it is famous for this quote that the problem is not bad people in healthcare, it is good people who are working in faulty systems. The book made a sensation in that it revealed that up to 98,000 patients died from preventable medical errors in US hospitals each year, which accounts for about 2 to 4% of all deaths in the United States at that time. Subsequently, President Clinton passed the Senate Bill 580, the Healthcare Research and Quality Act of 1999, renamed the Agency for Healthcare Reform and Research to Healthcare Reform and Quality, indicating a change in focus, and funded multiple patient safety focused projects. One of the examples is this popular 100,000 Lives campaign by IHI, which is our Institute for Healthcare Improvement, which reported that in 2006, following initiatives like rapid response team, evidence-based medicine for MI treatment, medication reconciliation, central line bundle, ventilator bundle, preventing surgical site infections by preoperative antibiotics, that they saved 122,000 lives over a period of 18 months across 3,000 hospitals. That is almost like 40 lives a hospital over an 18-month period. So what do we do at All of You? So we have a safety intelligence system. We follow our national patient safety goals, and we do audits and ensure those are followed. And we have a DHS Just Culture initiative. We do event analysis following unintended outcomes, which can be a root cause analysis, failure mode effect analysis, and sentinel event analysis. We have a Helping Healers Heal program and a Great Catch program. So I'll briefly touch upon every one of these. So this is our event reporting system. You notice anything unsafe, you are concerned about something, you don't question your thoughts, just report it out. And this is our SharePoint. When you click on our Internet Explorer or Google Chrome, this will take you to the SharePoint, and you can see this button, Safety Intelligence System. And it will take you to this form where you can put in information about the patient, what type of event, and so on. Our risk management department will go over this in detail with you. In 2003, Joint Commission released the National Patient Safety Goals Program, and this poster, you would see it in front of all our elevators in the glass box. So when you're waiting, you can go over it. But let me tell you what it means. So the first national patient safety goal is to identify patients correctly. So there are two ways. You have to use at least two ways to identify patients. For example, use the patient's name, MRN, or date of birth. This is to ensure that you're giving the correct treatment or correct medicine to the patient. Do not use bed numbers or room numbers while identifying patients, because patients get moved around, and you don't want to give the wrong order for the wrong patient by using a bed number, instead using the name, MRN, or date of birth. The next goal is to improve staff communication. This mainly pertains to receiving your critical results on time. For instance, when lab discovers a high potassium level, it has to reach to the provider on time so you can institute the appropriate measures. We have a paging protocol in the hospital. When you get your text message via your pager, it will be listed as emergent, urgent, routine, or FYI. Basically, emergent meaning you call within 5 minutes. Routine, you can take a little bit of time. FYI page basically would be something like the family is waiting for you. And this is to help you prioritize your pages. On a busy day, when you have like 10 pages on your pager, this will help you determine which one you need to call first. And let's say they are unable to reach you for some reason, your page is not working or in the middle of code, then the nursing staff will use an escalation protocol. What they do is, let's say the intern on call is, and it cannot be reached, then the medicine on-call doctor or whoever is listed on the escalation protocol will be called, and the third person on that will be your department chair, and the fourth person, which I hope never happens, would be your the CMO or associate CMO of the hospital. This is to ensure the critical result that high potassium gets to the provider on time so appropriate measures can be taken. And the other thing I want to touch upon is the appropriate use of communication orders. So when you get more familiar with your electronic health record, you would know there is a communication order you can use to communicate with the nurse. You can use this to tell them when to be notified, like when the patient has a fever or when a patient's family is at bedside. But do not use it for discharge orders, medication change orders. The common one we see is changing the rate of the heparin drip. It has to be an actual order, not a communication to the nurse. And a diet order or a wound care order, because a medication change order has to go to pharmacy. It shouldn't be the nurse who communicates with pharmacy. It has to go directly from the provider to pharmacy. And the goal number 3 is using medicine safely. This has some metrics for nurses, like educating patients about anticoagulation, but the ones that impact house staff directly are medication reconciliation and medication duplication orders. So medication reconciliation in clinics, any provider patient encounter needs medication reconciliation. When you get more familiar with our electronic health records, you can see this tab where there is this button called eCoach, which actually has a list of job aids that will help you through our medication reconciliation. But I understand, my understanding is you guys do have an ORCID training, which will touch upon all of these. I want to emphasize about this acknowledge button. Let's say you're unsure of a medicine that you did not prescribe. You can click the acknowledge button. So this is how your medication reconciliation page looks like. And at the bottom, there is this acknowledge remaining home meds. For instance, you did not prescribe the eye drops. You can, these buttons, your ORCID training will explain more, but this means continue, this means you're prescribing, this means stopping medicine. And if you didn't want to do anything about this, you can just acknowledge remaining home meds, and you won't be penalized for it. And on the inpatient setting, a medication reconciliation is needed upon admission, transfer from one unit to another, or at the time of discharge. This is another topic I want to touch upon, medication duplication orders. Avoid ordering 2 medicines of the same class for the same indication. For instance, for blood pressure control, do not order 2 ACE inhibitors, 2 beta blockers, 2 calcium channel blockers. It only puts them at risk for side effects. Let's say you're ordering 2 different medicines for the same indication, but it's like an as-needed medicine. Be as specific as possible to the nurse in your order, because it is not within the nursing scope of practice to decide which one to give first, which one to give second. For instance, for pain medicine, indicate if, let's say the patient is in pain, you order Tylenol. Patient's still in pain, you order Motrin. The patient's still in pain, you order hydrocodone. Indicate that Tylenol is for mild pain, like on a pain scale 1 to 3. Motrin is for moderate pain, which will be 4 to 6. And hydrocodone will be for severe pain, which will be 7 to 10. That way, the nurse can assess the patient's pain and choose which medicine to give. For nausea, let's say patient, you order ondansetron. Patient continues to be nauseous. You order metoclopramide. You have to clarify your order to the nurse saying, try ondansetron first. If it doesn't work after this much time, try metoclopramide. That way, the nurse doesn't give both of them together at the same time. So be as clear and specific in your order as possible. The next national patient safety goal is hand hygiene. As you know, is preventing infections in the hospital. And the important one here is hand hygiene. Well, it seems like a simple concept, but you would see how that we do not have 100% compliance here. So what is hand hygiene? It's cleaning your hands by using either soap and water or an alcohol-based hand sanitizer. Why do you have to practice hand hygiene? It is to avoid spreading germs to patients, to reduce your risk of colonization with these germs or get an infection from patients. As per CDC estimate, about 2 million people in the United States get an infection in the hospital, and of them, 90,000 die as a result of their infection, and you don't want one of these 90,000 to be your patient. And when to do hand hygiene? So we use the WHO's 5 moments of hand hygiene, which is before touching the patient, after touching the patient, before a clean or aseptic procedure like central line insertion, Foley catheter insertion, IV line placement, or a peripheral line placement, and after exposure to body fluid, and also after touching patient surroundings. So you see this dotted line around the patient, and which is listed, which is shown here as well. This is considered the patient zone, which is the zone where the patient is and whatever touching the patient is, which can impact, which can give an infection to the patient. Even if the patient is not in the area, you want to keep it as sterile as possible. So even if the patient is not there, like he went for an X-ray or a CAT scan and you enter the room, we do recommend you to do hand hygiene in and out because you don't want to inadvertently contaminate the area with the germs. And the hand washing technique. How do you do this hand washing technique? Hand washing, it seems like a simple thing, right? So you wet your hands with water, apply enough soap to cover all hand surfaces. You rub the hands together and wash with water and dry with towel. But this is the important one, number 4. You have to wash the front, back, in between your fingers, under your nails. I have some videos in our patient safety webpage that you can look at. I'll show you towards the end of this presentation. So studies have shown that the areas most often missed during hand washing are the thumbs, the fingertips, and in between fingers. So pay attention to those areas. And when you're using an alcohol-based hand sanitizer, you have to rub it till it dries. And if you used it for 10 times or so, we do recommend you wash with soap and water afterwards because it is not, your hands are all soapy and oily at that time. And also when you see a difficult patient or if your hands are visibly soiled, soap and water is recommended instead of an alcohol-based hand sanitizer. And appropriate use of gloves. This is another thing we see where the common misconception is gloves prevent contamination. Gloves are good and can be a substitute for hand washing. the gloves can get contaminated while wearing it and removing it, and it can transfer onto your hands. The germs can transfer onto your hands. So we do recommend hand washing with soap and water or alcohol-based sanitizer before donning gloves and after removing gloves. So the patient safety and quality team does do audits in clinical areas where we check for compliance and the reports given out to the different departments, the nursing leadership, and different departments in the hospital. And there are observers and there are also coaches. So if someone sees you not using proper technique or doing hand hygiene, in the interest of the patient, they would stop you and may coach you and help you not make the mistake again. The next national patient safety goal is reduce the risk of suicide. This is mostly in our inpatient psychiatry units and in the psychiatry emergency room, where the provider basically does a suicide risk assessment and categorizes it as low, medium, or high based on which the patient will be assigned a one-on-one sitter or every 15-minute rounds. Rarely it may apply to a medical surgical unit as well. The last national patient safety goal for hospitals is to help prevent mistakes in surgery, which is our universal protocol, which is making sure correct procedure is done on the correct patient at the correct place on the patient's body, and marking the correct place on the patient's body where the procedure will be done, and pause before surgery to make sure that a mistake is not being made. Time out. Let's move on to event analysis. We are in hospital and we are all humans. Errors do happen and unintended outcomes. You will encounter unintended outcomes in your career. And when we see that, we do event analysis. And with our new curriculum, all of you will be involved in analyzing these unintended outcomes as part of your patient safety quality education. And you will work with patient safety team, risk team, and in your department, and so you understand the process and the importance of these. So what is the purpose of these event analysis? This is to identify underlying problems, regardless of whether it caused harm or not. And with the information we obtain, we identify areas of change so that it doesn't occur in future. And we are looking forward to having your participation in these event analysis. And during event analysis on our side, we use the Just Culture principles, which basically looks at every event and analyzes what happened, what normally happens, and what does the procedure require, why it happened, and what we can learn from this adverse outcome. So we establish a timeline of from the time the patient got admitted to when the event happened. We use fishbone diagram, which is like look at everything that led to the outcome, and we use the 5 whys to identify why the adverse event happened. And with these, we try to address all aspects of the problem so it won't occur again and cause patient harm. Last thing I want to talk about is about second victims. Who are second victims? Second victims are healthcare providers who are involved in an unanticipated adverse patient event in a medical error or a patient-related injury and become victimized in the sense that the provider is traumatized by the event. They feel personally responsible for the unexpected patient outcome and feel as though they failed the patient and start second-guessing their skills. Some of the anxieties these second victims experience are, is the patient okay? Will I be fired? Will I be sued? Will I lose my license? What will my peers think about me? Will they ever trust me again? And what happens next? And, this manifests as physical reactions like palpitations, fatigue, insomnia. It may impact your concentration, your confidence in making decisions, and you can feel sad, scared, anger about these, and you kind of act like a post-traumatic stress disorder patient, where you have emotional outbursts or you're numbed and behave like a robot. This leads to burnout. Burnout is prolonged, unresolvable stress at work, and it even has a ICD-10 code, which is a billing code for as chronic elevation of cortisol. But burnout has been associated with lower patient satisfaction, infections, medication errors, and higher standardized mortality rates. I want to show this quotation from Naomi Raymond, which is, the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. So these things do happen, and we are here to help. And the program here at all of you and at our other DHS facilities is called Helping Healers Heal program. UCLA also has a lot of wellness programs and peer support. The ultimate goal is to help you recover in a healthy way and continue your career. You can contact us Monday through Friday at between 7 to 4:30 p.m. by calling Patient Safety. This is the extension, or you can submit a FI report where you can specify under event basics, refer event to Helping Healers Heal, and it will lead to a drop-down menu where you can put in further information, and somebody from the patient safety team, a peer supporter, will contact you. And I want to see if I can show you the patient safety website. So when you click on the Internet Explorer or Google Chrome, you will come to the All of You UCLA Medical Center. This is our homepage. And not working. Let me try again. This is the DHS homepage. Oh, there it is. So under departments, you will see patient safety. And it has our Helping Healers Heal program. And if you click on this hand sign, it will take you to videos where you can look at hand hygiene techniques and also the 5 moments of hand hygiene. And these are our Great Catch Award recipients. These are people who had done something to improve patient safety. Mostly submit a safety intelligence report that led to a process change that made it safer for our patients and prevent an adverse event. So house staff, as frontline healthcare people, we rely on you to keep us informed about unsafe conditions, near misses, care coordination issues, or anything that you feel needs to be reported by submitting a safety intelligence report. We rely on you to follow the national patient safety goals and, by performing hand hygiene, doing medication reconciliation, doing timeouts, and performing suicide risk assessments. We are here for you if you need peer support, and we look forward to see you participating in event analysis so we can fix faulty system issues. That's it for my presentation, and if you have any questions about any of these, I'll be glad to answer them.
Thanks, Dr. Sivasudhan. Do you want to take down your slides and see if anybody has any questions?
Yeah, I'm looking.
You can just hit stop sharing.
Oh, stop sharing. Hold on. How do I do that? Oh, there it is. I see it. Okay.
There you go. I gotcha. Okay, well, thank you. I know that was a lot of information, folks, but it is definitely important that you feel like it's part of your job to, if you see something, say something, you know. If you identify something that didn't go right, there's a system issue, that's what the safety intelligence reporting situation is for. It's not to, like, quote unquote, write someone up. Although if there is an unprofessional interaction, that is a place to put it. It doesn't go in the chart. Okay. What's very important is that instances of, I'm not sure. I don't think you said this. Did you, Lakshmi? That if someone does put a safety intelligence report in, it's important not to reference that in the chart, and vice versa.
Yes. Yeah.
That kind of chart. You want to explain why?
Yes. So when you put in a safety intelligence report, it goes into a separate system that our facility holds. It doesn't make its way into the medical record, and it is completely confidential, and it is for our internal process of fixing what happened. We do not want you to put it in the chart because let's say there is a lawsuit in future, it does not give the attorney a way to track through that report and ask for our safety intelligence report. So this is the safety intelligence report, or the system that the hospital has is protected as confidential information, and but please do not mention it in the chart in the medical record. You put in the safety intelligence system and wait to hear from us. Don't document in the chart.
Right. It's not discoverable, basically. And if you refer to it in the chart, then it could become discoverable, which is not what we want.
Yes. Yeah. Mm-hmm.
Okay, great. Thanks so much.